Welcome to Le Brionville's volunteer workshop. Presenter was Dr. Allan Fielding. It was facilitated by Labrie coordinator Lori Goodhand, and it was recorded on October 30th, 2024. We hope you enjoy.
So that's it. Based on the feedback we got, there was interest in learning a little bit about the Quebec mental health system, the role of Labrie volunteers. So how can we sort of flesh that out a little bit, and then a little topic on stigma. And then there were some brief mini topics on the illnesses. We'll see partway through if people feel they need to get up and just sort of stretch for a second or two as well. And so we might as well get right into that now. So here for part one, Quebec's mental health care system, and quite deliberately chose a maze as being the graphic that we would start with here. And we can see that when we go to the next slide, is that if you try to actually locate some mental health services, and you decide, okay, I'm going to go on the Quebec government's website under health, mental health help and support resources by need. And one of the things you'll start seeing right away is that it's actually very dense. And the first thing that we can sort of see is, okay, you say, well, call 811, or if it's an emergency, call 911, or if you're suicidal, call the suicide line or a crisis line. But right off the bat, we're starting to see that there's going to be lots of links in here. So it kind of gives you the feeling that you're going to kind of have to track things down. The next slide. So, and then when we specifically get into mental health care services and needs, they like to sort of really say there's a whole range of things that you can go for in terms of mental health services. And so what they introduce here is the notion of stepped mental health care services. And buried in this is they love to have abbreviations and acronyms. Is a mouthful called the PQPTM, which is the Programme Québécois pour le traitement des maladies mentales. And the idea behind this is that there's some people who basically just need to have some information and maybe pointing towards some self-help resources that they could use that would help them learn, for example, relaxation techniques or a little bit about their situation, what would be an appropriate way to get help. And then a notch above that might be, well, maybe some support meetings or group interventions, and then working their way up to having some basics of therapy, some of which they might just try on their own. There's lots of websites where you can get started on having some individual cognitive therapy work, or even just, do modules yourself on this. And so that's kind of the starting point that the government wants to not sort of have everything wind up in at the top of the pyramid at the hospital, but start with services that would be more localized, but also maybe more suited to where the person's starting point is, if we could say that. So for the next slide, again, one of the things that always pops up near the top, especially here in Quebec, is suicide prevention, and trying to get people to see one of the first things you should find if you're going on a government website about mental health care is, here's how you can get help if you're feeling suicidal. And then below that, they're showing sort of a range of telephone support services that people can kind of start with as another entry point. So we'll go to the next one. So a lot of these services are now really supposed to be accessed through your local CLSC. And so the next thing that we can see is that you'll get directed towards what is your CLSC. So I don't even know what my local CLSC is. It's not right next door to me, but that's sort of supposed to be the entry point for people moving into mental health care services. Yep. So what you can see down at the bottom is psychosocial intake. And so this is really supposed to be the starting point for people. If you don't have a family doctor who's already assessed you and said, yes, you require some mental health services, this is supposed to be the doorway into things. So the next slide will give us a bit of a feel. And so this program was started in about 2017, this PQPTM. And this is a rather dismaying slide, because what this shows is what percentage of people describe themselves as having either excellent or very good mental health. And look at the way the lines are going, and they're all going down. Now, of course, 2020 was when COVID kicked in, and so we might expect a lot of things to go in there. But that was, already several years into this notion of, wow, you can start with self-help, and then you can get help at your CLSC. And then if that's you need more than that, well, we can bump you up a little bit. So kind of one of the things that seems worrisome is, in spite of having these structures in place, the general mental health of the population is not really getting a lot better. So if we look at the next slide, their concept here is really this idea of stepped care. So you start with something that might just respond to a very basic need, information and self-help. So starting with maybe some resources you could read or where to go to chat with people, and then moving up to online self-help, and then through drop-ins, and finally to a therapist-assisted online program, and then intensive therapy, and then all the way up to psychiatric consultation, and if needs be, inpatient treatment care. And so a lot of this is really trying to move it into more of what they call a pyramid shape, where a lot of services will be for basic needs, and then for more complex needs or heavier cases of a person's illness, of more severe symptoms, that the top of the pyramid will be accessible because regular everyday problems are already taken care of down at the bottom. So on the next slide, what we can see is just reinforcing that, is that the entry point for mental health care services now is really through your CLSC. And I'll tell you the other exceptions a little bit later. But from the psychosocial assessment that takes place in a CLSC, again, that's where they are supposed to have some basic psychotherapy available, usually about 12 sessions. Each session will be monitored to see what were your symptoms when you were coming in, are your symptoms getting better? And if it looks like, wow, this is all you need, then that's kind of where your services will plateau out. And some very basic things like relaxation training or individual and group psychoeducation. We use psychoeducation rather than just education, I guess, to really say that the focus is on dealing with mental health issues and sort of what are some of the healthy approaches you can take in there. And then the idea is that if at that point it's kind of picked up that we might be dealing with a specific mental illness or something that will require an intervention different from what they can offer at the CLSC, then comes the referral to the psychiatric services. And so many of these could be a consultation with a psychiatrist actually at the CLSC. We have a name for these. These are called psychiatre répondant. They're responding to the needs at the level of the CLSC. Beyond that, people would move into something called a MEL, a Module Évaluation Liaison. So this is where, instead of having a psychosocial intake, that you would actually be referred to a psychiatric intake. So here you would see a psychiatrist, a psychiatric nurse, a nurse practitioner, maybe a resident, to actually have a psychiatric evaluation. If you are one of the lucky few people who actually has a family doctor, mine just retired, so I'm on the list for Lord knows how long now, they can do something called a centre de répartition des demandes de service. And this is where your family doctor can directly request a consultation with a psychiatrist. And what they will do is that they will give you a ranking from A to E. And A is you've got to be seen right away, and that means you have to go to the emergency room. And then B is, I think, within 2 or 3 weeks. C is within 6 weeks. D is within 3 months, and E would be within 6 months. And so the idea there is to say, well, we can really try and have a sense of how urgent is this, and hopefully have good pipelines for people to get in and get a psychiatric assessment or a mental health assessment relatively quickly. So on this side, what we can see is not all psychiatric services are going to be hospital-based. And so a number of years ago, it was really recognized that for a lot of people, their care should actually take place as much as possible in the community. And so again, we've got a wonderful list of little, I guess what we'd call acronyms here. So we have a CIV, a SIM, a SBINI, and a SIF. I only learned about the SIF when I was developing this presentation. And so really what these are looking at is, do you need to have somebody come to the person and actually be with them in their milieu to give them direct care and assistance? So oftentimes this is helping somebody maybe reintegrate into their community. It might be reminding them, have you taken your medications? Do you need to see your doctor or your nurse? But really providing them stuff in their environment at their home. And so the soutien d'intensité variable, you keep your doctor, you keep your nurse at the hospital, but you can have somebody come and visit you anywhere from maybe 1 to 2 times a week to once every couple of weeks. A suivi intensif en milieu is actually almost transplanting full hospital services into the community. And there you could actually be seen up to daily. And so sometimes people who are really having trouble keeping track of their medication, somebody could come every day and give them support and see how they're doing. The suivi de bas niveau d'intensité, these are people who only need to see once a month, once every couple of months. Somebody could pop in, have you paid all your bills? Do you have your groceries? Are you able to do your laundry? So sort of things that will help sustain people, but again, it's in their house or their apartment. And then the suivi d'intensité flexible is really for small communities. So these would be in rural Quebec, where you can't really put so many people as these other teams would require to provide services. And it's a very different type of service as well, where you'll be traveling around, for example, long distances to go see people. Next, so on this slide, what we see is, in addition to specifically mental health or mental illness-based services where you've got mental health professionals, we also have this amazing range of community-based services. And I just put a few here just to give you a bit of a feel. So many of you might know about Maison les Étapes, for example, or Forward House, which is one of the older resources that has been around for a very long time. And you can see that they actually offer both long-term support, but and a day program, but they also offer residential services for people who are transitioning out of the hospital and maybe have lost their housing because they got hospitalized. And again, Association Bénévole Amitié, you can see where for a lot of people, they would have a need for social connection, and not just during the day, but maybe even during the evening. And Up House is a very interesting one. It's based on the clubhouse model, where it is run by and for its own members. And so they include things like meal placements and meal services. And to give you a bit of an idea of what that day programming could be like at some place like Forward House Maisons Les Étapes, is just to show you the range of things that come in here. So ranging from pet therapy to photography sessions, they have their own radio and creative writing workshops and even knitting. So you can really see that there's sort of moving into the types of activities that can engage people, but also bring them out of their isolation. And so for a lot of people who are struggling with a mental illness, something like this is really quite fantastic. So we're quite fortunate in Montreal that we have a lot of these. And then also, I mean, people have their own natural caregivers. They may have families who are involved. So we're fortunate also to have a number of family resources that are specifically there to help people who are in a caregiver role. And also things that are arts-based. And so Les Impatients, Expression La Salle, and l'Atelier Centre-Ville are also other ways for people to have something very creative as an expression outlet for themselves. And we also see, you can see where you guys are in here, as a specific type of resource for people to help sustain them, but also provide through the whole ABRI program, a stable housing resource for people that can meet their needs when they're unable to really live on their own independently. And so one of the things that you can see if you took the map of Montreal, so we've got a nice little banana-shaped island, and if you put dots where all the hospitals are, is you will see that that pale green one in the center is where most of the hospitals are located, and you have a few in the East End and a few in the West End. But if you look at where the population is, it's actually kind of smeared all over the entire map. And so one of the things that happened is that that areas were designated as being hospitals should take care of this population to make sure that they could give a proper allocation of resources to deal with the populational needs. And so a number of years ago, it was thought that really we should try pulling all these things together. People don't just need a hospital. They would need CLSCs at some point or community resources. Is there a way that we can kind of pull these under one umbrella? And that's where the CIUS came up. So it's Centre Intégré Universitaire de Santé et Services Sociaux, a real mouthful. But basically what it means is typically you would have a university teaching hospital. So you've got your McGill system, you've got the U of M system, and with them would be associated various hospitals, large and small, and then other sort of resources. And the idea is that these can try and, by being lumped into CIUSs, and we have 5 of them on the island of Montreal, given how big the population is, that would allow services to kind of talk to one another, hopefully to be able to provide an appropriate range of services for their populations. And as you can imagine, the CUSs dealing with the west of the island would probably have a very different populational needs than maybe the ones dealing with the east of the island. And so the idea is that the CUSs can also not be a one size fits all, but begin trying to have services adapt to the needs of their population. And so just to pick one at random and show you the range of things that could fall within there that are all supposed to be linked and coordinated nicely in an ideal world. So you'll have your CLSCs. So in Centre Sud, there's actually 4 of them. They have 2 crisis centers where people can go where they may have a mental health problem, but primarily what they're dealing with is an acute housing problem. Guichet d'accès à la première ligne is where you can go for medical services if you don't have a family doctor. And then multiple health services, a lot of them community-based or online-based, and your famous groupe de médecins de famille, either universitaire or just a regular one. And these are groups of family doctors who you may not have your doctor in there, but if you've got a file in there, then whoever's available to see you can at least see your dossier and maybe give you some continuity of dossier rather than necessarily continuity of specifically your own doctor. And then when we move to hospital-based psychiatric services, so now we've kind of moved up that pyramid. You've done your self-care, you've gone to the CLSC, you need a little more, you maybe have a community intervention going on, you're plugged into community resources, you actually need psychiatric care and psychiatric treatment. And so oftentimes, unfortunately, the entry point is through the emergency room. And I say unfortunately because usually what that means is the crisis is built to a point where either the person can't wait to get services or that they're really doing very poorly. And so in an emergency room, after being seen by the regular emergency room doctors to make sure that there's nothing in terms of a physical health problem going on, you could have a psychiatric evaluation in a number of hospitals. So at the MUHC, at the Montreal General Hospital, we actually have also short stay units. And these are designed to give almost like a little mini hospital in the emergency room. So the idea is maybe by giving you a proper support, maybe a bit of psychotherapy, some family work, medication interventions, maybe we can help you pull together within a brief period of time, 5 to 7 days, and you won't need to be admitted to an inpatient unit. So not all hospitals have those. And what you can even see is within the MUHC, which has multiple hospitals in it, there's the Royal Vic down at the Glen site and the Montreal General. There's actually no psychiatric services down at the Glen Hospital. They're all located at the Montreal General, which is where we have our brief intervention unit. Inpatient treatment will then be for people whose situation is so unstable that it's really not safe for them to go home and where we haven't been able to stabilize them in the emergency room. And then following that would be the outpatient treatment. And so our outpatient treatment sometimes bypasses the inpatient unit. These would be for people who've been seen in the emergency room and can have either a crisis intervention follow-up or would be seen in our assessment clinic. And then in our outpatient units, most of the time clinics are based on diagnosis. So we'll have a mood and anxiety disorders clinic, maybe a clinic that deals with psychosis, a clinic that deals with personality disorders, and then also we have our day treatment programs. The notion behind these as a philosophy is the right care at the right time for the right amount of time. And one of the things that we see very difficult is that getting the right care can be difficult depending on where you live. At the right time can be very difficult in terms of accessibility. And for the right amount of time means that once you've got the care that you need, do we have somebody that we can send you back to who could continue that treatment program? And a lot of people don't have a family doctor who could do that. So while that's a nice, well-intentioned statement, we can almost say it's sometimes pretty difficult. On the next one, when we sort of look at what some of these diagnosis-based clinics would be, again, it's usually clustered around the main diagnoses. But what we also see is we might have a unit that deals with addictions. We have different types of treatments that are non-medication treatments that can help with things like depression, obsessive compulsive disorder, and anxiety, like magnetic stimulation or electroconvulsive therapies. At my hospital center, we have something called Music, the McGill University Sexual Identity Clinic, where we really help people who are struggling with their sexual identity, and the specialized therapies. including music therapy, ketamine clinics, and cognitive therapy. And finally, if you're at a university teaching hospital, chances are that you might also be offered integration into a research-based program. When you're there, one of the things that can be a little overwhelming is just the number of people who potentially can be involved in your care. But to give you a bit of a feel, most of the teams now in outpatients, and also in inpatients actually, are interdisciplinary teams. And somebody really pointed out to me the difference between, what is it, multidisciplinary and interdisciplinary. Multidisciplinary, you'll have a bunch of different disciplines there. Interdisciplinary, they all work together. And so our goal is for them to actually all work together, provide complementary services, but also be able to talk about what are the needs of this particular person. And so do they need to see the occupational therapist because they're walking down the school or work road? Do they need a psychoeducator to help them with their educational needs? And do they would they benefit from a music therapist? And chances are, if you're in a university teaching hospital, you run into trainees, either in nursing, occupational therapy, psychiatry residents, psychology interns, and residents. So the whole group, and we shouldn't forget our support staff, because without them, it's very hard for these things to work. So what I can tell you is that, when they have this notion of right care at the right time for the right amount of time, when we look at other things, like for example, I had hip surgery 10 years ago, but I don't see my hip surgeon anymore. But if I had diabetes and it was a brittle diabetes, I might continue to see my endocrinologist full time. So the flexibility we have to have in there is also, what is the intensity of the problem? And is it the sort of thing where somebody is really stable? So for example, say you saw a psychiatrist or some other psychiatric staff who was working with you, your condition stabilized nicely, you've been stable for 2-3 years, they see you once every 6 months. That's probably a sign that maybe somebody else could follow you. Now, what you also put your finger on is we see that approximately 1/3 of GPs want to have nothing to do with psychiatric care. About 1/3 will say, I'll do it, but only if I have access to a psychiatrist who can guide me and chat with me and maybe see the patient again. And 1/3 love it. And I have somebody I see once a year because his GP refuses to prescribe a medication that hasn't changed in 10 years. So yes, you can see that within the system, this notion of being able to, if you're very, very stable, float in and out of care, of more intensive care.
We've asked you to either put your question in the chat or to raise your hand. Jane?
Yeah. Hi, Dr. Fielding. As you were explaining the many arms of the system, I was thinking, now that many patients' files are online, are these systems sharing that information?
So I'm smiling because a lot of hospitals internally use a system called Oasis, and Oasis is an electronic chart. Interestingly, if you come into the emergency room, they're going to use something called MedUrge, which is separate from Oasis. And what appears in MedUrge doesn't show up in Oasis, and what appears in Oasis doesn't show up in MedUrge. So you actually have to have 2 screens open or 2 files open when you're in the emergency room, looking at what did the outpatient doctor or nurse say, and what am I going to do here? Then when you leave the hospital system, you can only access Oasis remotely. So and not all charts are electronic. So they're getting there. I find at the MUHC, we have this really cumbersome system where I can chart electronically, but my prescriptions get sent and scanned and then entered in as a picture into the chart. So there's a little ways to go for that. So the Quebec government thought that maybe there should be a single universal system that could be implemented all through Quebec. And I think the system they were going to implement was called Christelle. And among healthcare professionals, the word was that the people who were making this decision were on Christelle meth, meaning, what kind of drugs are you on? This is a horrible piece of software that nobody likes. All the pilot projects have just said, please don't use this. So it's kind of stalled. What we do have now is, your Dossier Santé Québec. So your Dossier Santé Québec is, unless you've said, don't look at this, your lab results, your x-rays, your medications will all show up in a file that pretty much any doctor or or a nurse practitioner can access with the proper credentials. It's password protected. We had to have a special key that we insert in the computer, a double verify our identity. You can see whoever looked at your file. So you have a safety check there. And you yourself can actually look at it yourself if you get your carnet santé. You can't look at it right away, but you can look at it eventually. So that's kind of a basis. And I think the idea was that eventually they would like to add layers to that to be able to put a universal chart so that, yes, you would be able to go into a clinic and people would be able to access your chart. The flip side to that is some people are, of course, very concerned about privacy and accessibility.
So the CLSCs would be sharing with the hospitals.
So that would be the idea, is that if you could get a universal platform, then you would be able to do that. Yep.
Okay,
Yep.
great, thank you.
So it is a good ideal. And again, one of the nice things about an electronic chart where you type in is you don't have problems reading people's handwriting.
One of the thoughts I have about this is just one of the lessons I've learned is to really have to advocate for ourselves with our information, and that anytime I end up seeing a doctor is I always ask for a copy of whatever, results I need so that I have them in, in paper for myself, so that
Yeah.
I sort of carry around a dossier of my own for if I go see someone. It seems to be necessary these days. Pepita?
I don't see how any normal person can figure out where they go, where they stand in all this, and how they can advocate for themselves if they're dissatisfied with the level of care they're getting. Now, and I'm talking about a person who's relatively well. Somebody who is in bad shape, there's no hope. I mean, how do you manage this nightmare of bureaucracy? I know you said, well, we should give up on the pyramid, but from a pyramid to this, I'm concerned about our residents. I'm concerned about my family. I'm concerned about anybody who has to face this.
So one of the things, and I guess as just a person living here, and I'm sort of going, okay, as a citizen, just putting along on my own, have I ever heard of the PQPTO? No, and yet that's what I'm supposed to turn to if I have a mental health problem. And then I'm going to Google, okay, Mental Health Services Quebec, and again wade through that big website. So yes, I think what happens is we can see on the one hand, it's too bad because there are a lot of really good resources down at that bottom level, a lot of self-help things that people could really use. And again, I think if it was better integrated into workplaces, if it was better integrated into schools, if people, when they went to see their family doctor or went to a clinic, also could pick up something that says, hey, have you thought about looking at this? You might find some of the resources good for you. So I think there's also, as with a lot of things, that problem with communicating it down at a level where people can actually use it. And I think it's why people wind up in emergency rooms. So I think this was, again, and you can see within the design of the system, the idea was that if people who don't specifically need a specialist can get care delivered at the level that they need, then you free up the specialist to see people who actually need specialty care. And that's the theory. And then the practice is, so how do you make that happen? Yeah. So I mean, there are some interesting things on the horizon. There's more use of nurse practitioners now. I think there's going to be an increased attempt to integrate them into local clinics so that you can get something more quickly. It's interesting when you look at models in other countries. My son lives in the United States right now and happens to have a job that gives him excellent care. But I mean, he can reach a nurse practitioner on the phone almost pretty much 24 hours a day and can then get directed to somebody within 24 hours. And it solves a lot of problems. And that includes some basic mental health care stuff as well.
Is 811 not the same sort of model? The idea that you can call and speak to someone, whether it's through physical health or psychosocial support, as an entryway. It can be a wait, but that's the principle, that you might be able to talk to a nurse practitioner at that level.
Yeah, I wanted to say something really so the one thing was, I think we also wanted to check in with people about having a break after this.
Oh yes, do you need a stretch break or do you want to go forward?
If people wanted to get like a 5 minute, and it would be a hard 5 minutes because even me, this is pushing my bedtime. So if we wanted to do that afterwards, but one of the things that I did want to say, and thank you so much, Dr. Fielding, this was so helpful. We have volunteers that have been with us for many years, and a lot of our volunteers were familiar with the mental health care, particularly in the kind of central area in Montreal or West, when it was much different. And this is so invaluable because I think sometimes it's a little bit, there's a feeling that if I'm working with a resident that I'm close with, why is there this kind of circuitous route that's needing to be navigated while this person is decompensating? Why can't we just call up the psychiatric nurse? They have a good relationship. Why can't they present at hospital? And I think that this was kind of invaluable because it presents the kind of reality that I know myself and the coordinators and some other folks are definitely aware of, where when you're watching somebody struggling, but for many years, their clinical or treating team has said that they're stable. So all those levels of support have kind of gone through attrition. That person is then trying to get back into the system essentially. And so I think it was really helpful because I know some of the volunteers here, they've worked in the mental health care systems in Montreal, and it's significantly different from what it was when Labrie started and for many years when they were providing services as volunteers.
Yep.
So thank you so much for that.
Okay, so part 2, and I think Star wanted to start us off on this section.
Okay. So first of all, now we're talking about the role of an actual Labrie volunteer. And so where I wanted to start with that is just to say thank you. A lot of you know who I am. I was a coordinator and worked with many of you in that role, and now I'm the executive director. So I wanted to say thank you so much to the volunteers that have been with us for so many years. The relationships, I think, is with volunteers and residents is one of the things that's most attracted me to Labrie. For new volunteers that are coming in, it can be a big kind of community to wrap your head around and how it works. Supportive independent housing for folks that are managing with life with mental illness isn't a really common model. So thank you so much for being willing to get involved. And then the next thing I wanted to talk about is a really important part, because essentially in all of the things that we were just talking about before and getting to understand what the scape of the mental health services in the city looks like, the person that's in between a volunteer coming and saying that they're concerned about something is often the coordinator. And so I just wanted to have a review because I know sometimes it's changed and it changes about schedules, but right now to kind of reiterate that we have 3 coordinators. So 2 of them work 3 days per week. And I think all the coordinators had just sent the volunteer groups out emails so that it's a little bit more familiar who's working when, because that can help to de-escalate things. If you know on that day you can reach them or you can leave a message and they'll get back to you on the day that they're working. And then there's one coordinator that works 5 days a week, and that's Michelle. And then there is the student coordinator. Right now we have Morgan. And so a question that we often get is, if I see something when new volunteers come, who should I speak with? And the very first person that everybody should speak with is the apartment coordinator, because they're, again, the direct link. And I know sometimes, because I have had the role of a coordinator and now I'm in the position that I'm in, but I also still work really closely with the residents and I have good working relationships with the residents, that there can be a question if I'm involved. Rest assured that I am always involved, but I also have like the utmost confidence in the work that the coordinators are doing. They know the most about the situation. And the other thing is that sometimes when I'm involved as well, it creates a bit of a game of telephone and it can kind of complicate the work. So the coordinator is always the person to go to. The next thing is we are all Labrie. And so this comes from situations where a resident could be struggling. And there can be what's called some splitting happening, where the belief is that they don't want the coordinators or other staff members to know, or maybe even other volunteers or people in their life, and you're concerned about what's happening with them. We've gone through more than one situation like that, and it's really difficult. But what came out of one of those situations in talking with folks is that there's an opportunity there to talk to the resident and say, we're all Labrie. It's not that the volunteers or the residents or the coordinators are separate from Labrie. We are all part of Labrie. And I think that can also be a helpful way to respond when you're concerned about what's happening, and a way that's caring, and a way that can maybe make it so that you're bringing people into the conversation sooner than later. And then the last thing is, what can be shared with me from a coordinator? That's difficult because we do have to be respectful sometimes. And I know that that can be challenging for the volunteers. It's challenging for the coordinators and the residents. But I think one of the things that is really helpful is that if, as a volunteer, you're saying, it would help if I had more information about this person's personal history, it's to think about, how would that help? How would having that information make a difference in the situation that you're facing right now? Because sometimes residents do become quite ill and they're not maybe the same as we've built the relationship with them. And I think in that time, it's okay to remind yourself that sometimes it can be hard to step away, or maybe to set boundaries around a relationship that you had with somebody who's changing, and you have a good idea that it's due to their illness, and maybe the coordinator is affirming that, and that doing that is okay. It's okay, and sometimes that can be protective of the relationship. So a coordinator can meet you in that place of talking to you about, I'm worried because I feel like if I could know more, then I could do more and somehow help. And a coordinator is a really good person to talk through that with. It might not be that there's more information shared, but maybe there's some help there about how to step away or how to put boundaries in the relationship that make a little bit more sense for you at that time, and maybe protect it. And then the last thing is that I've often said that Labrie is like a relay race. And that's one of the reasons why I love it, is because what I've always seen is that people have an opportunity, residents, volunteers, coordinators, people that come on as board members, our advisory council members, they come up and we're so lucky that they show the best of themselves. And that it's so important to kind of maintain that relationship with our volunteers and the link that the volunteers have to the residents. So one way that that can happen is we've become a lot more organized with our activities lately, and also a lot more organized with sending out the information about what activities are available. I thought Joan was going to be here tonight, but I would thank her because that volunteer bulletin was one of her ideas. It's really helpful for us because we're always working on resident attendance, because it helps to address things like social isolation and helps them to integrate into Labrie. That the volunteers RSVP, especially when we're having activities where there's food involved. You RSVPing gives us an opportunity to kind of plan, and it also means that we can encourage the attendance of the residents and that you can participate in that as well. The next part is kindness and respect, and I see a lot of that at Labrie in all directions. But it's hard to stay in that place if you're faced with something difficult for a resident, either because they used to have a support that they don't have anymore, and it's difficult to watch that, or maybe they are becoming ill and not themselves. But it's important to remember that the coordinators are seeing that too, and it's hard for them as well. And I think there's a difference between calling a coordinator up and saying, it's really difficult for me to watch this person that I care about struggling, and I'm not sure what to do, versus maybe a coordinator being the one that's at the brunt of the frustrations about the system that we just heard about that might not be working its absolute best. And the last thing is that there's limits to supportive independent living. It's one of the reasons why the kind of housing and support that we provide is so important, but it's also really challenging. And it's especially really challenging right now because of the way that the mental health system is set up, among other things. And it's important that the volunteers know that, because a lot of times what was relied on in the past, which would be these long-standing relationships over decades and decades with the same nurses, social workers, and psychiatrists, that's not the field that we work in anymore. And although we might get used to our residents in one way, a lot of times we when we see them not doing well, for clinicians, they don't see it at the emergency level we do. And so it takes some time. So there's limits to what we can do in our roles. But I hope that you believe that we're trying our best. And I'm going to stop there.
Go
Just
ahead.
a comment, I'd like to stress what Star just said. And given the complexity of the system as it is now and the lack of, help we get, our coordinators are doing extra work to be able to advocate for the residents so that we volunteers, we have to give them the credit that's due to them, this additional load on this additional workload and the difficulty that it entails, because as you saw, managing that maze is increasingly difficult. So not only is it difficult for me, but it's difficult for the coordinator that has to advocate for the resident who's going through a tough time. And I just wanted to say that, rah for our coordinators.
I want to take a second to say right back to all the volunteers, because I know I can see everybody on this screen. Everybody here, I know as well as the coordinators, have personally talked to, and you've been part of us when we're trying to rally those supports around. So the thanks goes back to you all as well, so much.
Thank you to both of you. So we're going to keep having this discussion, but Dr. Fielding is going to present some of his slides. And then if it's okay, you can save your questions to the last 10 minutes as well.
There we go. So, and I think it's been mentioned, but it's worth really kind of reinforcing as well the unique nature of Ville with this mission statement of really the stable and fulfilling environment for adults who are managing life with mental illness, with really the safe, affordable housing and inclusion in the community that is supportive to them. And so what you can see is when I work in a hospital setting, I'm going to see somebody. I oftentimes talk about this. I remember somebody saying, this is the time in between visits, and this is how much I'm seeing them for. I've got a little slice that I'm seeing and intervening with, whereas their life goes on in all of this space. And so that's where something like Labrie comes in, is that's where they're living, and that's where their support is being delivered. So, and again, when you look at how does this translate into what you do, so a lot of it is actually that developing the skills that are needed, supporting people in learning things, but also really building, I like this, the building the bridges to the wider community's participation with residents in social activities and shared interests. And when we get later on, we have a little slide on some of the problems that people with mental illness face. And certainly social isolation and being cut off from things is such a big one, that having a community that is invested in them and that they can be invested in themselves really brings a different dimension to their care and support. And so you can see this in, I like this is pulled from the ABRI website, and some of this is pulled from, when I was speaking about this to volunteers before, is, so if we think of it in those ways, you're supporting people, you're moving them forward, you're helping them learn certain things. I oftentimes talk about, knowledge, attitude, and skills is how we move forward. Part of it is just that, being a resource person. And so when we were talking this notion of you're not expected to have the expertise to handle a crisis directly, but you should be able to say, I know who I'm going to call, and I know how I'm going to put this into the pipeline to moving it forward to a more positive. But it could also be for other things, that if people want to branch out from things right within their particular apartment and be more involved in their community, that's where things can come into helping them do that sort of research. The other thing is, and again, what you can see is that for a lot of people, that their illness, as it may fluctuate up and down, might also have an impact on their relationships. And so that notion of hanging in there to say, at this particular time, I was almost thinking sometimes, you need to be alone and sometimes you need to talk. And it's that process of being able to flexibly say, okay, I thought you needed this, but I might have been wrong, but I'll come back later. And I'll say, well, you didn't want to talk before. No, you've got that willingness to get back in there and give it another try. And again, for a lot of people, if they feel that they have alienated their loved ones or other supports or friends, I don't know how many times I talk to people who say, in their depression, you know, I don't want to see my friends because I'm going to just bring them down. And then you say to them, but if you had a friend who was depressed, would you want them to you know, how would you feel if they spoke with you? And they say, well, I'd love to be there to support them. And so they almost can't flip it around. I don't want to be a burden, but I wish they would open up to me. I would like to support them. And so navigating that can be difficult. And so this is where, again, that process of being able to hang in there and sort of give things another time. And I know that there's this, I guess it's a new program about the more task-oriented, time-limited volunteering option. So that would be interesting to see, where you can see there might be times when really you're intervening. I know we have this model in our hospital a lot, where with our, for example, our occupational therapists, to say, is there a particular skill that you need to acquire? Is there something that would help you move forward? And what could that be? And could I help you actually connect with that or learn more about it? And then we can look at, again, when we're going to get into stigma a little bit, you can see this expressed in social isolation, people who isolate themselves because they don't feel they fit in, or who are isolated because other people don't feel they fit in, is that accepting presence. And this is the idea of not being scared off by the illness. And, you know, it's so striking when we're going to talk about stigma in a few minutes, is, you know, Halloween is a time when I was just looking the other night, flipping through the channels and what's on TV. Well, of course, it's all the horror movies. And what's a favorite theme in the horror movie is somebody with a mental illness who's, you know, going berserk and, you know, is like crazy or whatever. And you sort of go, wow, what a bad time to have to sort of be struggling yourself with a mental illness, if that's kind of how things are portrayed. So if you can understand that I'm not going to discriminate against the person, I can be accepting. There will be times when they will be functioning better. I oftentimes say being sick doesn't bring out the best in us necessarily. So you may not be seeing people at their best, but if you're not scared off by that, then you provide some of that constancy that can be there. And that's where this willingness to work it through if a conflict arises. And that stability, I think this is from your website too, building community flowing from the long-term nature of relationships, is that if people can sense that degree of stability, and especially as you started to point out how in our mental health care system, you know, as I'm looking at, again, winding down some of my practice, you know, I'm speaking with some people, they say, Dr. Fielding, I've been seeing you for 35 years. And that model is not there anymore. That model is changing. And so, again, where does their stability come from? Accompaniment is another one. And, you know, it's interesting when you look at if somebody moves into different levels of housing resources, is stuff being done for them? Is it being done with them? And if it's being done for them, do they ever learn how to solve a problem? Do they ever learn how to acquire a skill? Or can they, again, be presented with stuff of, okay, what do you want to have happen? And how can we help you make that happen? And again, being able to move out into the outside world and build those bridges. And then modeling is a particularly important one. You know, we often have this talk the talk and are you walking the walk? And this is one of my favorite ones when I look at, you know, we know that exercise is good for everybody and it's good for almost everything. And one of the favorite cartoons I had that I stuck on the wall in our gym in day hospital was a woman sitting and talking to her doctor. And she said, last time we met, you asked me to think about exercising. What would you like me to think about this month? So it's that translating it into, you know, do we model caring? Do we model respect? And when people can see that modeled around them, then they have a good idea of sort of, okay, this is how it works, you know, respecting boundaries, but also committing to communicating, committing to problem solving. And finally, the modeling of the value of structure in one's day. A number of years ago, people were looking at people with severe long-term illness, mostly schizophrenia, on hospital wards. And they said, you know, they look terrible. They look like zombies. They don't get dressed. They don't, you know, take showers or shave. We need to get them out of the hospital. And they put them out in a house in the community. And somebody came back after a few months and they said, oh my goodness, you know, they're not getting dressed. They're not showering. They're not shaving. That, like, what happened? He said, well, for them, it's like a Sunday. If you have nothing to do, like, and somebody said, so what do you do on Sunday? Do you get up and shower and shave and or is Sunday kind of your day off? Well, if you have nothing meaningful to do and you're not going anywhere, why would you bother? And so there was really that notion is that housing is one part of it, but then that structured day and the things that you're involved with and engaged in is what actually makes you want to get up and get moving and get going for some things. Perspective is an interesting one, and this is where, you know, both your life experience or life experience of other people you can tap into, or just being a sounding board. You know, sometimes we teach this notion is if somebody's asking you, what should I do, is very different from needing to sound off to you about how their day was. And so you don't necessarily need to know answers to things. And sometimes it can be a challenge to distinguish, am I supposed to just listen, or do you actually want me to give you a piece of advice on this? But that's where that perspective and sort of acting as a wise parent can come in. And then again, a basic notion about teaching as well. For a lot of things, you may have a particular skill set, or you might feel comfortable or have fun moving forward in something. I know in our day hospital program, we have a kitchen group. And a lot of people say, so am I going to learn how to be a cook? And we say, no, 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 but you might get over your fear of chopping vegetables. And it's also a wonderful social time as everybody gets together and make a meal together. And you can kind of forget how wonderful, how nice that can be. So some of the questions that then come up sometimes is, and this is one of them, is should volunteers know the diagnoses of residents? And again, I think that the feedback that it's here, and Star vetted this as well, so we can sort of say this, it's not specifically necessary for most of your interactions. But again, if it needs to be sort of bumped up to the level of a coordinator, is, you know, this seems to be going on. Am I wrong? Am I missing something? Or is there a good reason for this? There might be times when that might help you understand. But most interesting is to really get the residents' own understanding of their illness. Not just their diagnosis, but how does it have an impact on them? And so, you know, we often talk about mild, moderate, and severe levels of illness, but you can also have mild, moderate, and severe phases of an illness. And you can have a time when, you know, it's just really not working for them at a particular level, or at a time when it's really going well. But certain illnesses will bring about certain particular challenges. Where I work in the day hospital, oftentimes the challenge people have is low energy. And so we're really looking at, well, okay, how can we make something happen accommodating the fact that you have low energy, or in spite of the fact that you have low energy? And so that's really living with the demands and the effects of treatment. Oftentimes, I'm pretty sure your residents will be being treated with pharmacotherapy. And pharmacotherapy, while it might be very good at helping stabilize certain things like symptoms, also comes with a bit of a price tag. And so should volunteers talk about their diagnosis with residents, as in listening and trying to understand? Again, sort of really what I'd encourage you to think about is, how does it translate into something functional? So for example, are they anxious in social situations which would make grocery shopping difficult? And can you brainstorm with them and give wise counsel around this? Sometimes we can even look at, I know I oftentimes will, I guess, rely on myself when I sort of go, gee, if I have a choice of when to go shopping for groceries, it's probably about 10 o'clock on a Monday morning. Because by 10 o'clock, they restock the shelves, but there's nobody in the store. You know, you sort of go, okay, yeah, that's not bad. Sometimes I do stuff at Costco and I sort of go, maybe I'll go really early, and I get to Costco really early, and everybody else thought maybe I'll go to Costco really early. And so then that's not the best time. And I said, maybe I could go really late, and then realize they shut down the store on you. And you're looking for that sweet spot that accommodates, you know, your own sense of how much can I tolerate in certain circumstances. So that's where, again, oftentimes you can provide those creative solutions for them for something that's going to be a skill that would be good for them. Same thing. Are they a morning person, an afternoon person, or everything's hard for them? And can you brainstorm around that with them? Or do they have difficulty concentrating, remembering, and making memory is a useful tool? In day hospital, I oftentimes hold up three things. I said, I don't know anybody's phone number. It's all in here. I have a lot of stuff to do in day hospital. It's all in here. And I'm, I don't have it here. I'm a paper agenda person, so I have my paper agenda. And I have one staff person looks at me and says, seriously, you have a paper agenda? I'm visual. That's me. So yep, that's how I like to see my week. So again, it's really adapting it to how can somebody adapt things to where they're at, and can you help them even be creative about that? And is being non-judgmental and friendly the best use of volunteers? And it's hard not to stress this enough. That stigma is still a major problem. People with mental illness, even with problems like programs like Bell Let's Talk and our pharmacy run for women's health. We feel particularly fortunate at the MUHC that Farmer Pre's Run for Women's Health usually benefits our programs, and it's quite strong thing to go and see so many runners in a given place, all running for women's health, and in particular women's mental health. But again, the fact that we still have to keep doing these and having programs like Let's Talk shows that we still have an awful long ways to go for people feeling accepted in communities. And so by maintaining the social connection that is free from stigma, you can actually create a base for residents to feel more accepted and hopefully more confident about going out into regular life situations. And again, you're really modeling and setting the tone for their own peer support. Is you can see how by looking at respect and communication, that by modeling this, you can hopefully have that also be the norm for residents in dealing with each other. And so this I thought was an interesting slide that I came across when preparing for tonight, of different ways that we can reduce stigma, and we're actually going to focus in on stigma a little bit more in a few minutes. And one is just learning about mental health and mental health issues, so that it's not based on what you think you know, but what you actually know. And then being able to talk openly with others about mental health and the notion of sharing, and using people first language. So this is a tricky one, and I think I have a slide on this later. Is there are illnesses that are seemingly all-consuming, and we oftentimes, for example, refer to somebody, especially in medicine, as a diabetic. Well, he's a diabetic, and we don't usually say he's a person with diabetes. And it can happen that way as well, that people can be referred to by their illness as opposed to a person with the illness. And normalizing treatment. Again, in one of the next slides, I'll see you would expect somebody who broke their arm to go seek treatment. But it's surprising how many people who are struggling with a mental illness problem are actively discouraged from doing that, because it's a sign of weakness, or you should be able to handle this on your own. And then recognizing self-stigma. So self-stigma can also be our own process of difficulties in dealing with our own limitations. We can do some questions here, and then we can kind of open it up a little bit. Got about another half hour after the question period, so we're good, I think.
So we'll go for questions, and I'll look, put your hand up if you have a question. And I just wanted to return to something that Star said at the beginning in terms of the structure that we have. So the coordinator of the apartment that you're supporting is the person you go to first. But, knowing that, for example, Leah and I work 3 days a week, it becomes a discerning question for you. So if it's a question that's not urgent, you want to have a discussion, then obviously it's an email to us or a phone call to us during our 9 to 5 work hours. If it happens to be, oh, I had a discussion with my resident, I'm concerned about something they said in terms of their safety or somebody else's safety, then that becomes an urgent, you need support quickly, and it's on a day that Leah and I are not working, then it becomes a phone call to one, I guess it would be Michelle, right? One of the other coordinators, Star, who can then triage it up to Star if it's needed. If it happened, you happen to be out on an evening and this happens, I need an urgent, should I leave this person alone tonight or not? Then you have access to the on-call line that we have in place for now. So you can, as a resident, can call, a volunteer can also call to speak to somebody, and that we rotate. So a volunteer, one of the coordinators takes the phone once a week and has it for the week. So you will get a callback. I think most of you know that you leave a message on the machine. You won't speak directly to somebody right away, but you leave the message, your name, what you're concerned about, and the person who's on call will call you back. So that's the structure we have within our organization to try to support you non-urgently, or also to give you the urgent support if you're with a resident and you feel like you really are concerned about something imminent. Any questions about your role as volunteers or any of the information that's been shared so far?
What's self-stigma?
So I can give you a little story. Years ago, I had a psychotherapy patient, but I was feeling very sick. And so at some point in the session, the person said to me, I don't feel you're listening to me. And I actually ended up being bluntly honest and said, it's because I'm trying not to throw up. And she said, I wish you would have canceled. because then at least I'd have had a good session and felt that you were listening and able to help me. And I realized that internally, my own self-stigma was the patient's allowed to cancel, but the doctor's not allowed to cancel. I will have this expectation of them. They're supposed to be able to talk to me about, wow, okay, I'm having a rough day, but I'm not supposed to have a rough day. Or I'm supposed to be able to handle my own needs. And so a lot of it can also be that way, or we can feel, I'm supposed to be able to handle what's going on with the residents at Abri, but you may not be able to. And so if you feel I'm supposed to be able to handle this, but what you really need is to discuss it with someone or bounce ideas off somebody else or event, then that's that kind of notion of, I'm supposed to know this stuff. Another maybe funnier way of putting it is I used to be an examiner for the Royal College, which is the final exams for people becoming specialists. And when we were looking at people training for that, one of the things we said is, if you know you don't know something, you're going to go look it up or ask somebody. If you don't know that you don't know something, you're dangerous. You should know that you don't know it. And so, I oftentimes try and reflect that back on myself. If I don't know something, I'm going to be pretty straightforward about saying, I'm going to look this up, or I'm going to check it out, or I'm going to get back to you, because I can't know everything. But I might know a colleague who would know, or I might be able to ask somebody. But if I know that I don't know it, it's a lot better. So if I think I'm going to make a medication error in dosage, I look it up, and I'll look it up right in front of the patient, and I'll say, I'm looking it up because I want to make sure I don't make a mistake here. It's better than me relying on my memory and then giving you a bad prescription. So again, some of that self-stigma can also be what's our expectation of ourselves as a mental health professional, as a specialist, as a volunteer, and are we able to sort of go, maybe this is a little tough for me. One of the things that, we also have all our lives, and our lives can, in our interactions with other people, it can touch on issues that are important in our lives. And, I found when around the time that my parents died, I was very sensitive to loss in other people. And, I came across a little thing today and was talking about milestones that you move on from, for example, with your kids, and realized I'm very sensitive to something like that. Now, that might make me overly sensitive in some of when I work with my patients. I need to recognize that rather than say, no, this is not going to interfere. I'm going to, no, this is probably going to interfere. I better think of that beforehand. So does a long-winded answer, but does that sort of help a little bit? It just kind of says everybody's human, and you're going to be human dealing with the residents. And there might be times when your buttons are pushed, or when you're, or it could also be that your little spidey sense is going off, going, I don't know what's going on, and it's not me, so I think something might be going on with them. Is there a way that I can sort of nip this in the bud or move it up so that they'll get the help they need?
Thank you. It's very reassuring.
One of the things you might also notice is that the residents have a lot of their own self-stigma as well when they express themselves. And if they're courageous enough to tell you about a fear that they have, a fearful thought, I'm afraid when I go outside that, people are talking about me, for example. Sometimes I find I have a resident who might use the words like, it sounds crazy, eh? I'm crazy, but this is what I'm thinking. And so what I find helpful is to kind of encourage the person to put that line, let's like flip that and put that language aside. What if, like a lot of us, you just happen when you go outside, it's really stimulating and you feel really fearful? Let's just use that language like that. So if you're really fearful when you go on the street, how can I, or how can we work, and help you, or how can you help yourself to get back to safety? So we take away some of those, I'm crazy, it's my diagnosis, all that stuff, and we just look at it in terms of their experience as they're going outside and how difficult it must be. And so you ally with the emotion and try to help them with strategies that would return them to safety and take them away from that, which unfortunately some of our residents have been in psychiatry a long time, where a label was, a diagnosis was put around their neck and not much education about the illness. And I feel like they still carry a lot of that. So that's a huge role that we all have when someone expresses, how hard it is sometimes to be living their life with some of the experiences that they have because of the illness that they're managing?
So I think and we sort of try to touch it in here, but when you're looking at the impact of their illness on them. And so sometimes it can be almost an empathic response, like if you imagine for yourself that it was true, that would be really scary. And so sometimes you can have the acknowledging of the emotional impact of the symptom, which is that must be very scary for you. And sometimes you might need to recognize that we might see things very differently, or we might have a very different experience of this. So while you might, when you go out, feel that you're being, under surveillance, whatever, I might have a very different experience walking down the very same road. But I can understand that if that's how you feel, that must be extremely frightening for you. And then you're focusing on a functional aspect. So how could we do this so that you could still go out and not be so concerned about that? Is there a way that as we're going along, you can check and see that, okay, if I've gone this far and nothing bad has happened, maybe it's okay that I can go out. And even if I feel I'm being under surveillance, it still shouldn't stop me from doing what I want to do. And then you can maybe do the accompaniment that would allow them to feel a little more secure. But that's it. For a lot of it is again, what we can see is for many people, particularly delusions can be very frightening. And so it's being able to resonate at that level of if they're experiencing that as true for them, that must be very frightening. But is there a way, and you can, sometimes the reassuring can be, I think we're probably going to be pretty safe. At least that's my own personal experience, is that we'll be safe. But how could I help you then move this forward? But it is a little tricky. You sort of have to see at times what we do say, when we teach about delusions, we say it's a fixed false belief that doesn't respond to reason and is not culturally or religiously congruent. So meaning, I worked with somebody who was Wiccan, and in Wiccans have, trees have spirits. So she wasn't psychotic, she was Wiccan. And she would hunt down her totem animal and her tree spirit. You sort of go, okay, so within that, that's fine, but is that comforting for you? Is that dangerous for you? And if it's very uncomfortable for you, so how can we work with that so that we can move you forward, where the goal is to be functional? Again, a response to that can be, I'm never going to leave this house. I mean, that's really kind of a non-functional response to life.
Helpful. I also wanted to share that the residents, many of our residents have been with us for a long time. And you would have seen them at peaks and valleys managing their symptoms. And I found one thing that's helpful sometimes with the residents is when they're saying, this is what's happening right now, is saying, oh, has this ever happened before? What did you do? And it's almost like a prompt to remember, I have been here before. And sometimes they have skills that they are better using when they're more, it's just like anybody. If we get scared or panicked or in the moment, you forget about even the resources and the skills you have yourself. But to say, oh, tell me, have you felt like that? What does it actually feel like? What does that feel like? Is your chest pounding? Have you felt like that before? And what did you do? And that can be a way to kind of almost like, I don't know, I can't think of a better word, but trick them into being like, oh, I do have all these things. I've worked so hard to be able to have a life that I enjoy and do these different things. But in the moment, it's hard for me to remember. That's a really helpful thing too, I find with the folks that we often see at Libri.
That's a good one. Yeah. Do you have a skill that you've learned that helps you deal with this at this particular point? And it might be, I need to do a breathing technique. Or it might be, for some people, it might be, I need to take a PRM. Or it might be that I need to, wait a half an hour and then do it. That's it. When we look at cognitive therapy for psychosis, it isn't aimed at them specifically saying what I'm feeling is not true. It's there's no evidence that this is actually an imminent danger for me now. Is that even if I feel I'm under surveillance, it's not an actual dangerous situation for me right now. And they can do a different appraisal of their environment. But that's something that happens. But again, they might have learned that as a tool. I love that idea. Have you learned? You probably had this happen, or have you had this happen to before? What did you do before that worked for you to help you get through this? Yeah, nice. So that's it. It had come up that people wanted to talk a little bit about stigma and struggles that people have with that. And So on the next slide, what we talk about is, stigma is one of the components that people really have oftentimes when they're faced with a mental illness. And it can include social isolation, poverty, the illness burden. So the illness's burden would be carrying around a lot of the symptoms. So it would be, for example, feeling chronically slightly paranoid, or feeling always depressed, or feeling always anxious. And then sometimes we also forget the treatment burden, which can be medication side effects, but also the burden of going to see, having to do follow-ups. We have a family member who fell ill recently and had never been sick in his life, basically. And he said, wow, all of a sudden I'm a patient. I have like 4 medical appointments this week and I have to do this. And all of a sudden there's, like, as we could call it, almost like patienthood, that can be a burden for people. And then when we look at stigma, it is really both prejudice about, or negative attitudes, and negative responses. So it's not just thinking badly about somebody because of their illness, but then it's actually responding to them as something, as them being different or lesser. And so it can almost, the impact on them can make them feel unwanted or shamed, as if it's somehow it's their fault. We see this a lot when earlier, that self-stigma question of, I have no reason to be depressed, but I'm depressed. Yeah, you have a perfectly good reason to be depressed. You've got depression. So, and we could look at the next slide. Yeah, so lack of understanding of the illness, I sometimes point out how, if you broke your arm and you put and you got a cast, almost nobody would say to you, that's just big plaster talking, soak that cast off, what do you need a cast for? But people will say to you, you're on an antidepressant, you're on an antipsychotic medication, seriously? Like, why are you on that? It's almost like everybody's an expert. Or people extrapolate inappropriately from their own experiences. Yes, most of us would have had the experience of being anxious or being depressed, or maybe be feeling, euphoric because things are going wonderfully. But it's almost like the difference between a cold and a flu, that they're not exactly the same. And so oftentimes we see that the illnesses are also seen as socially unacceptable. It is quite fascinating if you looked at the history of AIDS, where at the beginning it was an ultra high stigma illness, until all of a sudden it looked like, half the people in Hollywood and musicians and very famous people had it, and all of a sudden it was, wow, this is something we need to do fundraising for, and a massive change in the notion of it. So again, excuse me, these typically mental illnesses are kind of seen as socially unacceptable. Do I have another one there? Oh, and then, yeah, perpetuated by portrayal in the media. I've spoken about this a little bit already. And then, again, this is what we look at is people will accept the notion of medical, genetic, or biological underpinnings for most illnesses. And again, not always, but if somebody says, I had a heart attack, sometimes people will come back and say, well, it's because you're, 100 pounds overweight, eat too much fat, and you're hypertensive and you smoke too much. And they'll sort of, almost like pin it on you. But a lot of people go, oh yeah, you had a heart attack, sort of thing. And again, we kind of accept that there's these other underpinnings. We don't blame people so much for having cancers, but oftentimes people will have a different sense, almost like, what the old saying was, lack of moral fiber made you have these illnesses. And I've mentioned this already, how we don't refer to, there's a cancer in bed 4, but we will say there's an alcoholic in bed 4. And so it makes it harder to for people to deal with the illness itself, and oftentimes stops people from getting help. When we look at, again, how daunting this accessing to mental health can be, when, working your way through the system, somewhere in there, you have to take that leap and actually go somewhere. And so when they're looking at, okay, are there things that you can start with online? That's one of the ways of trying to get around that maybe you can go help look for things. Just a little aside, and this was one that was really quite difficult. There was a concept that antidepressants caused suicide in young people. And when they started looking, one of the things that was so striking was the number of young people who were on antidepressants that they just got off the internet. And antidepressants don't give you a buzz. So you have to kind of go, why were they hunting for an antidepressant? And could, in fact, some of the things we see that were suicides in people who are on antidepressants is because they were hunting for help. They didn't get the help. They thought they would self-medicate with an antidepressant. and it was an untreated illness that took them out. So again, and we can see a couple different levels of stigma and sort of, public, self, and institutional, where certain stereotypes are embodied in laws or institutions. You may have seen in the news today that Quebec is allowing advanced directives for medical aid in dying. But one of the more difficult ones that they have is that mental illness as the sole underlying disorder does not appear as a reason that people can request medical aid in dying. So that one has psychiatrists divided right down the middle on that one as to whether it should even be there. But you can see that we have very much an embodied, a public and an institutional notion that this is a radically different set of illnesses. And so again, there have traditionally been lower funding for mental health services. And it's really interesting to see with Bell's Let's Talk and things like Pharmacy Run, where things are very clearly being funded for mental health issues. And so people can really get on board that way. This one was an interesting one for us when we did an outpatient survey. We didn't think that we would appear on the list. And here it goes is, what's the least helpful aspect of your current treatment? And one of them is the stigma of coming to the hospital. And for a lot of us who work there every day, sort of go, well, it's just the Allan Memorial and that's where we go. And, and without really thinking of somebody new to the whole system sort of going, I have to go to the Allan Memorial Hospital. And then they look it up, or Allan Memorial Institute, and they look it up and they go, oh my God, what a horrible, terrible place. And all these terrible things that happen there is sort of, and that's where I have to go. It's almost how low have I sunk that I have to go to a psychiatric hospital. And so, again, sometimes when you work in the field, you miss how difficult that could be for somebody coming in from the outside. And so, again, when we look at our own individual efforts, talking about mental health issues, educating yourself, being conscious of our language, encouraging equality between physical and mental illness, and showing compassion. These are all some of our individual efforts, and you can see that echoed in your approach as a volunteer as well. And being honest about treatment. I had a beautiful story about this. Years ago, I was working with somebody, and every fall she would get depressed, and she would go on antidepressants, and every spring she would go off. And then, so that meant that each fall she was sort of having to readjust to her antidepressants. And she was talking with her neighbor, and her neighbor said, "Are you okay?" And she said, "Oh, I'm started back on my antidepressant, and I've got a bit of a dry mouth." And the neighbor goes, "Oh, I'm on Zoloft. What are you on?" And all these years they had been there and had never been able to sort of break through that notion that both of them were actually struggling with depression. And these were just a few little ones that I pulled from a really interesting website called Tokyo Mental Health. We should make it clear that getting help isn't a sign of weakness, it's a sign of strength. The next one is, we as a culture have not fully acknowledged how much help is needed. The only real shame is on us for not being willing to speak openly, for continuing to deny that mental health is related to our overall health. We need to start talking, and we need to start now. No one would ever tell a cancer patient, just get over it. Why people think they can tell that to a person with a mental illness is baffling. So one of the first ones was just kind of looking at this diagram of mental health versus mental illness, and where do we situate these in there. And the notion that when we have an optimal mental health, we are flourishing, but you could have optimal mental health and still have a mental illness. What we can see and how we can sort of deal with these is, if you have the appropriate habits that allow you to function well. Again, if I can use somewhat of a bit of a funny one, you can have diabetes and have a pretty good optimal physical health because you manage your blood sugars, you eat well, you exercise, you control your other risk factors. So you are living well with diabetes. And so we can see sometimes we can live well with different illnesses. But if we have both poor mental health and we have a serious mental illness, then we can really see that this can have a major. So what we can see is that certain illnesses can also skew things in a particular way that can make it difficult for residents to even have some interactions with you. And so one of the things that we can see is that most of the time we do respond on a very regular basis to the person in front of us and I give an example. I said, if you want the most unfortunate one we see now, you're talking to someone and they're always on their cell phone, or if you want to try it yourself, someone's talking to you and keep looking over their shoulder at somebody in the distance, is that all of a sudden they get very uncomfortable. And so part of what that means is we're continuously interacting with people looking for visual and verbal cues. And yet one of the things that can happen in schizophrenia in particular is oftentimes that emotional reactivity that comes in is blunted or is not as common. And so you can almost wonder sometimes, am I bothering the person, or are they connecting with me? And we also have something in our speech called prosody, which is kind of the musical content. We use different levels to convey meaning. So for example, you should go up for a question. Are you coming? And we would go down if we wanted to express, you know, our disappointment or anger. Are you coming? We can do the nuance of, are you coming? Where we turned it into a different type of question. So all of those, if you just looked at the words, and this is one of the things that happens when somebody texts you, and why people have to stick something on the end of a text to say, I'm being sarcastic, I'm being funny, I'm being sad, or whatever, is musical content of speech is extremely important in conveying meaning. But oftentimes that's one of the things that can be a bit difficult for somebody with schizophrenia to process, in which case they're sometimes not too sure of what's going on, so they may actually have difficulty following things. And something called concrete thinking. And concrete thinking is where the usual hierarchy of thoughts might be altered. I remember going to a lecture at ME Quebec, one of the, back then it was the low beer lectures, and somebody who had schizophrenia who was lecturing on it spoke about how, you know, if you say, when I say hand, what do you think of? And somebody might say glove, and they said somebody with schizophrenia might say hawk, because you put your hand up if you're a falconer and the falcon would land on your hand. And so that for them would be an equal response to glove. And so sometimes the notion of the thinking can be more distorted or can have difficulties. You could see how this could introduce difficulties in communication in both directions. And the next slide. So poor self-care can also be a part of the illness. And again, some of this is sometimes it's also almost a bit of a self-stigma. Why do I bother? Why do I care? But again, the capacity to recognize this is a good thing for me to do. Years ago, I remember seeing a video that was called Full of Sound and Fury. And one person had Post-its on their mirror in their bathroom: brush your teeth, wash your face, comb your hair, as being sometimes these things would need to be cued rather than being spontaneous. And again, I mentioned this about motivation, is if there is not something meaningful structured into the person's life, kind of what do they have to get up for, and why would they be pushing themselves? So that notion, when we talk about structure in your day, but also, is there something meaningful in their day that they're engaging in that then makes them want to move forward? When we look at their internal biological clock, sometimes in schizophrenia, there's a bit of day-night reversal. But something that can be quite striking for you as a volunteer in a breed is that without recognizing how important you are in their lives, you might actually be perceived as somebody very, very, very central to them. And especially when you've developed that relationship of care and respect. And again, on occasion, you will see that lack of insight, which makes them have difficulty with the notion of, I've got to continue treatment, even if I'm feeling okay. In bipolar disorder, I think one of the things that we can see is oftentimes people think, wow, it might be nice to be high. Actually, it's really hard on people to be high over sustained periods of time. And it's particularly hard on people around them, where it can be very, very, very draining. And so pressured speech and ideas might make conversation very difficult. This is a particularly bad mix in emergency rooms, where people come in and they want to talk to you and they have a lot that they want to say to you and they want to get it conveyed very, very quickly. And people are in a rush in the emergency room. And it's, as I said, oftentimes that's a really bad mix. And so it can be really quite difficult sometimes just to continue the communication. And especially this notion of, how can I be sick when I feel so good? And yet oftentimes in bipolar disorder, especially if somebody's moving into a high, the lack of insight might make it particularly challenging for you as a volunteer, that you would see things that don't seem to be quite on track. But the person themselves, having a lost insight being one of the first things to go, might feel that they're actually doing really quite well. And if somebody is rapid cycling, it's almost like you never know what to expect when you walk in. Are they going to be a little bit up? Are they going to be a little bit down? Or are they going to switch from up to down even while I'm talking to them? So that can be a little bit difficult. And if people have the excess energy that they have to burn off, but it is non-productive energy, then that can be hard on other residents as well. If somebody is almost being very, very busy at nothing. One of the difficulties sometimes people get into is impulsive overspending, which can then be very difficult on their budget. And certainly when we see the other end, if somebody crashes into depression, bipolar depression is probably the most difficult type of depression to treat. Oh, and again, yeah, we oftentimes see this in major depression where people see themselves as a burden and that, why are you with me? And I don't know if you encounter this in any of your residents. We're saying, you know, why are you bothering to come with me? I'm not a very worthwhile person. And the negative skew on life can be very difficult. I was just chatting with somebody today who has an extremely severe case of depression and has been in it for the past 8 years. And it's almost like we kind of go, well, you know, this is not that adapted to where you really want to be. And it's, well, why would I change? And we're trying to get them to say maybe a change could be beneficial for you, but it's very hard to do because, again, for somebody who has a limited capacity to feel hope or feel that there's something coming down the pipeline that might be better for them, then you know, you can feel very frustrated. I'm trying to motivate them, I'm trying to lift their spirits, but it's intrinsic to their illness that they almost have a basic incapacity to do that. Again, one of the ones that is the most difficult for us sometimes, especially around depression, is the uncomfortable topics like trying to deal with suicide. And so again, one of the problems we can get into with almost all of these is really affecting the person's level of energy, especially if they're on large doses of medications, which might be required to help control some of their symptoms. Is that in and of itself making it difficult for them to function? And how do we get into that proper balance between getting the treatment you need or being so sick that you can't function? Really good. So a couple of things to remember as a strength is that by building a relationship over time, you're probably in a position to pick up subtle things fairly early. And again, when we talked about you know, closing the loop on if I see something, I can also ask what's going on. And sometimes people are reluctant to share because it's very personal. But sometimes what you can see is, you know, a bit like me with my poor patient who's saying, you know, I don't feel you're listening, and I'm going, I'm trying not to throw up, is you could catch somebody on a bad day, or you could catch them with something that's happened to them, and you're picking up in a very sensitive way, you seem to be a bit off. And sometimes it can be even a very practical thing. If somebody's, you know, has missed their medication doses regularly, or has had, you know, a difficult interaction with somebody. And so I guess that idea of, you know, I seem to be picking up something, is there something going on, can be a very sensitive first step. One of the things that can happen also, you know, when I'm talking about how your interactions with them will be hours and my interactions with a patient might be minutes, is you know, if you have that, if you're with them and they do have an appointment with somebody, is also that whole process of coaching the communication process with their healthcare professionals. Again, you know, an example I use for teaching, years ago I was with somebody and his mom was with them. I said, how are things going? And he goes, oh, not too bad. And his mom, nice Italian mom, leans over, whacks him on the back of the head, tell the doctor. Oh yeah, I was involved in a car accident. I totaled my car. I go, oh boy, wow, are you okay? And the whole thing, yeah. He goes, okay, okay. So yeah, and apart from that, how's it going? Okay. Tell the doctor. I think I got my girlfriend pregnant. And it was like several big things like this. And you started going, okay, you could have walked in and walked out. And I know, like, I got it from my wife once when it was sort of like, what do you mean you told the doctor you're okay? You're actually in serious pain from sciatica, you know, like self-stigma there, you know. No, it's okay. I'm okay. So sometimes there can also be a usefulness there in, okay, what of this do you want to highlight to your nurse or your doctor that you're going to see that might also convey? Or even, is this the time when we should, you know, start looking, you know, do you need to see somebody else? And it may not necessarily be a nurse or a doctor in mental health that they need to see. You know, people have physical health problems as well.
Thank you, Dr. Fielding. I just want to give the last few minutes over to Pepita, who had a question.
Actually, I'm glad to get the last few minutes because I want to
Appropriate.
thank you. Yeah, it's so appropriate, isn't it? I want to thank you so much. This has been really enlightening. I've been a volunteer for a while. I'm now president of the organization, so that's why I freak out over the mental health system. But as a volunteer and as a person who has a mental illness myself, I found this totally enlightening. and really, really helpful in both how I handle my own illness and how I can handle the residents I meet with. So I really want to thank you from the bottom of my heart. This has been really wonderful.
Oh, thank you so
Thank
much.
you.
I never know when I'm doing something like this where I'm pitching it at the needs level. And I really appreciated the feedback from your survey and helping me kind of structure things for you tonight as well. Yeah, it's really useful.
Thank you so much to everybody. I also wanted to add that it would be great to have feedback from you. I can receive that directly if you want to send me an email. For example, some of you may think, oh, I want to explore this area a little bit more. Then we can perhaps look at having another workshop. So we really welcome your feedback because we want as much as possible to make your experience good, to feel well supported, and to make sure that you feel well equipped in the work that you're doing. So over to Star for the last minute.
The very last thing that I was going to say is so much thanks to Dr. Fielding, but also I just wanted to have a chance to thank Lori for all the work that she's done, all the work that she continues to do for the volunteers, all the work that she did in setting this up. I didn't want this to end without Lori getting a thanks from everybody as well.
It's been a pleasure.